Hey guys, am I audible, visible? If I'm audible and visible, do let me know. Let's start the discussion. Okay. Good afternoon, guys. So sorry for coming on a very untimed thing, and we'll have a very quick discussion. We won't be wasting much of your time. Very quick discussion on liver pathology, right? So there are very little number of questions which can come in liver. Most of the questions which come in liver are mix and match of whatever we're going to read. We're going to read about jaundice, a little bit about alcoholic liver disease, which will also include cirrhosis there. Also, we'll go to portal hypertension. Hepatitis is definitely a very good, very important question which can come in an exam. But I'm sure that you must have read hepatitis very detailed in microbiology, right? Like I said in the last class, that's the advantage of the second prof. You have lots of overlap, and I'm sure you will be able to solve the questions, write the answers from any of the subjects what you have learned. Fine. Hello, Karthik. What to take your name? I hope you're doing good, right? Good evening, Devangan. Good evening, Lion. Good evening, everyone. Karthik, change name to unknown artist. That's much. Karthik is much better than unknown artist. Fine. Okay. So without any delay, let's go to liver pathology. Hello, Rahul. Okay. So first thing is about the same template I'm going to use. Etiology, risk factor. Never forget these headings. These headings are the one which is going to fetch you marks in your final exam, right? Etiology, risk factor, pathogenesis, progression if you can know, clinical findings, lab findings, gross, microscopy, and prognosis if it's possible to write prognosis. Fine. Okay. Perfect. So let's go to the next first topic. So today first topic is jaundice, right? So can anyone here define jaundice? I'm sure everyone knows jaundice, right? Rahul's second year exam is a very simple exam. We are reading Farre for that. Try to follow us. If you have any doubts, do ask us. We'll be able to solve your queries. Jaundice is nothing but an elevated bilirubin level, which can be seen visibly clinically in the form of icterus in your eyes, mucosa, and in your skin. That's the definition of jaundice, right? So it's nothing but an yellowish discoloration of skin, mucous membrane, and sclera due to increased level of bilirubin. Jaundice per se is not about only conjugated or unconjugated, any one of them, right? Thank you, Karthik. So the normal bilirubin level is zero point 0.3 to 1.1. Some books say 1.2, some books say 1. That's fine. In that ballpark, zero point 0.3 to 1 is a normal milligram per deciliter is a normal level of bilirubin. So we have two different types of jaundice, and I want you to mention if there's a question on jaundice. We call something as latent jaundice. Can anyone tell me what does latency mean? Latent infection, latent symptoms. What do you mean by latent? I'm sure you must have learned about latent, right? So what do you mean by latent or latent, whatever it is? Latent is something which is not clearly visible, right? Latent infection means it's not clinically visible, it's there, but the infection is there, right? Perfect, a hidden one. So latent jaundice means anything from 1.2 to 2 milligram, anything less than 2 milligram is not clinically evident. This is definitely an elevated bilirubin level, but not seen or not clinically visible. The patient will not have a yellowish discoloration of skin, mucosa, or the sclera. That's latent jaundice. And then obviously have the clinical jaundice. Clinical jaundice is anything more than 2 milligram percentage. We can call it a clinical jaundice, right? Anything, like it can be 10, it can be 20, it can go to any extent. We call it clinical jaundice. Anything more than 2 will be clinically visible. We call it clinical jaundice, fine. So this information is required, right? Thank you, Karthik. Okay, next we'll go to classifications. We have two different types of classifications. I would prefer this to be explained in detail because that is easy for us to remember because we know the normal bilirubin metabolism. If you want to explain the things in terms of conjugated, unconjugated, mixed also is fine. Based on the bilirubin is elevated, we have conjugated, we have unconjugated or mixed. Well, are both conjugated and unconjugated hyperbilirubinemia based on the level of damage. This, like I said, is a bit easy for us to recollect and bit easy because you already know the normal bilirubin metabolism, right? So can we just recap normal bilirubin metabolism? It's not required to write an answer, but everything is based on this normal bilirubin metabolism. Where do you produce bilirubin from? Bilirubin is nothing but a breakdown product of heme. Heme is broken down in bone marrow, liver, or spleen. Predominantly in the spleen, right? It's a heme breakdown product. So when the heme or when the RBC is broken down predominantly in the spleen, it's where your everything starts, right? So from the RBC, from the spleen was being destroyed. Okay, uh, just ping me once on my Insta Rishikesh, it's Dr. Ranjith _AR. So I'll try to help you with that. Fine. Okay. So this, the entire unconjugated part here, it's not conjugated. The unconjugated part goes to the liver. Just to make it shorter, liver does the job of conjugation. Can anyone help me in saying what conjugation? Liver conjugates bilirubin. It's your glucuronide conjugation, right? We have glucuronide conjugation. Two conjugations happens in the liver. Once it happens in the liver, it's exited, right? It exits in via the biliary radicals, intrahepatic, extrahepatic, gallbladder, goes into the intestine, intrahepatic circulation, either leaves via urine or via stool, right? It gets excreted. I'll just write it gets excreted. This is the normal thing, right? In simple words, right? So here, anything which happens above this, we call it a prehepatic jaundice. Anything which happens below this, we call it post-hepatic jaundice. And anything which happens with respect to the liver, we call it a hepatocellular or a hepatic jaundice. Hepatocellular as well as hepatic means one and the same, right? So what do you think will be the major cause of prehepatic jaundice? So only one thing. Prehepatic, there's only one thing involved, which is breakdown. If there is more breakdown of hemoglobin, obviously the bilirubin which is coming into the liver will be elevated, right? So obviously it's simple hemolytic anemia, right? So prehepatic jaundice, you can write whatever you want. Like I said, the advantage of second year is it's not limited to one organ system. If you want to write extra words, write whatever hemolytic anemia you know. Okay, hereditary spherocytosis, thalassemia, sickle cell anemia. Want to make it bigger, you can make it bigger. If you want to cut it short, just use the word hemolytic anemia, right? Any hemolytic anemia, by default, you'll have excess amount of RBC lysis or the heme lysis, and that is going to cause an excess production of bilirubin, conjugated or unconjugated. Every prehepatic jaundice by default will be an unconjugated hyperbilirubinemia, because it's going to happen in your before entry of liver. Obviously, liver is the only one which is going to conjugate. So I'm going to have lots and lots of bilirubin which is going to come into the liver. My liver cannot conjugate everything. So predominantly I'll have an unconjugated hyperbilirubinemia. Fine. That's your prehepatic cause. Post-hepatic is simple. Post-hepatic jaundice, there's one more name for post-hepatic jaundice. Anyone? We also call them an obstructive jaundice, right? It's obstruction. It's most of the time result of obstruction. The obstruction, again, you can write anything. Can I say a gallstone can cause an obstruction? It can. A tumor can cause an obstruction. It can and it will, right? So obstruction can be anywhere, right? From the gallbladder calculi, could be a gallbladder carcinoma, could be an obstruction to the your sphincter of Oddi, right? So anything, your ampulla of Vater, your pancreatic head tumor, anything, right? So obstructive jaundice, I can call it surgical jaundice also. It could be starting from your gallbladder. It could be as simple as a gallstone, or it could be your CBD stone. I can have common bile duct stone, or it could be tumors in the pancreatic head. Tumors obstructing the outflow, tumors of the pancreatic head. That's a very classical percentage of obstructive jaundice. Okay. The reason why it's called surgical jaundice is most of these have surgical management. I'm not going to do a medical management for removal of a gallbladder calculi or a CBD calculi or a pancreatic thing. Fine. The unknown artist, see, it will not cause kidney fatigue, right? It's based on how much you drink. If you drink 10, 20 liters of water every day, it's going to dissolve many, many things, not just kidney. But 3 liters, 4 liters of water per day is not going to cause anything. Your kidney has an amazing capacity. It will do its own job. Fine. Let's come back to this. Obstructive jaundice, one of the classical clinical features of obstructive jaundice, in addition to your icterus and everything, is pruritus. Pruritus is a very classical feature of obstructive jaundice, and it's obstruction. So please tell me what type of bilirubinemia you will see. Will it be conjugated? Will it be unconjugated? What will be the major one? It will most of the time be conjugated hyperbilirubinemia, because what happens here is the obstruction is happening after the liver. So the liver did its job. The only problem is I'm not able to eliminate it properly. So predominantly you have conjugated hyperbilirubinemia. Perfect. That's obstructive. Hepatic cause needs to be dealt in detail because the question is primarily in the liver chapter, right? So hepatic jaundice can be of multiple causes. You can call them sporadic etiologies. You can call them some syndromes of hepatic jaundice. There are few classical syndromes. I'm sure you must have read the syndromes. Classical syndromes of hepatic jaundice, right? Good evening, sir. Good afternoon, sir. Okay. Can I say anything which will destroy or damage the liver can cause hepatic jaundice or hepatocellular jaundice? It will. It could be as simple as a viral hepatitis. Leave hepatitis. Trauma can cause it, right? Anything which can damage the liver can cause hepatocellular jaundice. Could be a viral hepatitis, could be a bacterial problem, could be a liver abscess, right? Which organism causes liver abscess? You guys know from your microbiology. You can write anything, right? In other words, any hepatocellular damage can cause a sporadic cause of hepatocellular jaundice. Fine. Okay. Entamoeba histolytica. Perfect, right? Any hepatocellular damage. Okay. Okay. You're speaking good, Karthik. It's just some time. Okay. That's it. Anything. A tumor can cause, radiation can cause, hemochromatosis can cause, Wilson's can cause, right? Any hepatocellular damage can definitely cause hepatocellular jaundice, right? It could be anything, right? Hemochromatosis can cause, Wilson's can cause, right? Anything can cause. Most of this hepatocellular jaundice, which is sporadic causes, are generally mixed hyperbilirubinemia, because I will not be able to exactly say whether the damage is affecting the conjugation or it's after conjugation. So you'll not be able to exactly tell them. So it will be both conjugated and unconjugated bilirubin will be elevated in most of the jaundice. I'm going to look at the bilirubin level, that's all. Now, syndromes of hepatic jaundice, we group them into two groups, right? One, there's a problem in the excretion. It's an excretion issue. Other is a conjugation problem. So whichever has a conjugation issue, conjugation related thing, obviously the conjugation fails, the patient will have an unconjugated hyperbilirubinemia. Which is having excretion is like your obstructive jaundice, which will have a conjugated hyperbilirubinemia, right? So since a conjugation failure, you can write here itself, there will be an increased amount of unconjugated bilirubin. Since then excretion failure, there will be an increased amount of conjugated bilirubinemia, right? Most of the other ones are mixed type of hyperbilirubinemia. And here I don't mind, because jaundice is not the primary problem in hepatitis, it's a symptom. My goal is something else. Hemochromatosis Wilson, goal is something else. Amoeba, jaundice is not the primary problem, it's just a symptom here, fine. But here, jaundice is a primary problem because bilirubin metabolism is getting affected in symptoms, fine. Three things: Crigler-Najjar, Gilbert, like Lion said, and your Dubin-Johnson. Rotar also, if you want to add, you can add. If you forget Rotar, it's fine, because Rotar is not very important, at least from a second year point of view. If you remember and write Crigler-Najjar and Dubin-Johnson, Crigler-Najjar and Gilbert, that should be more than enough, right? So Crigler-Najjar, if it's again, see whether it's a short answer or a long answer. Based on that, trim it. If it's a long answer, based on that, write it a little bit more, right? Crigler-Najjar, there's an defect in the enzyme UDP glucuronide transferase. Okay, a UDP glucuronide transferase, that's a problem here. So I have two types. The type 1, I'll have 0% functioning enzyme. Type 2 of Crigler-Najjar or type B of Crigler-Najjar, there'll be reduced enzyme, right? If it's 0% functioning enzyme, can I have conjugation? There'll be no conjugation at all, right? So this will present very early presentation, and the patient might end up in having kernicterus. What do you mean by kernicterus? The bilirubin, the unconjugated ones, will go and cross the blood-brain barrier, and it can entirely damage the brain, which we'll lose the kid, right? It's definitely almost always fatal. You'll not be able to save the kid, right? Type 2, they'll be reduced. Yes, the patient will be icteric, but there's a possibility to treat. Treat is to increase the enzyme activity. So we give enzyme inducers. I'm sure by this time you must have gone through the general pharmacology. There's a huge list of enzyme inducers, right? We can give enzyme inducers. Can anyone name at least one enzyme inducer? Treatment is just enzyme inducer, which can lead a pretty normal life, will not result in kernicterus, fine? Perfect. Gilbert. Gilbert, again, this also is a mutation. Phenobarbital, phenytoins, all those groups, rifampicin, there are multiple enzyme inducers, right? Phenobarbital is generally useful. Rifampicin, again, it's a liver related thing. We won't use that. Phenobarbital is a commonly used enzyme inducer, right? So also there's a mutation in the same enzyme, UDP glucuronide transferase. Here, it's actually a binucleotide repeat. If you want to add extra points, you can write it's a binucleotide repeat sequence, like your trinucleotide repeat syndromes of your Fragile X and everything. Same way, I have binucleotide repeats in UDP glucuronide transferase. So the enzyme is not working properly, fine. So here, it's mostly an asymptomatic case. Only if you're going to evaluate the patients for hyperbilirubinemia, the patient will come into existence. Most of them will be in the latent jaundice. Nothing much to worry, and obviously you cannot treat it. Just make the person informed you're having a problem. That's all. Okay. Dubin-Johnson is an excretion defect, right? So here I have a mutation in an enzyme called as an multi-drug receptor protein 1, right? So it's going to be a mutation in your multi-drug receptor protein, right? So because of this multi-drug receptor protein, there's a problem in the exit, right? MD, multi-drug receptor proteins, that's going to be mutated. Okay, MDRP2 is an abbreviation for a multi-drug receptor protein. Because of this, you will end up in having cholestasis. That's an important thing in microscopy because I'm not able to send them outside. All of the bilirubin stores inside the hepatocyte. We call it cholestasis. Chole is bile, stasis is staying. It's cholestasis, right? That's a microscopic finding. In addition to that, it's multi-drug, right? It's not one, it's multiple. It's a multiple drug receptor protein. Not only your bilirubin gets elevated, there's one more thing which gets elevated, right? So which is your Rohit, I am not able to understand your question. Can you tell me in what context it is? Hello, need target. Okay, you will have the norepinephrine, all those metabolites also will not be removed. So you'll have a black deposits in the liver. The black deposits could be a norepinephrine product or a lipomelanin product, right? So black deposits in liver is also a classical finding. Again, it's an excretion problem. So this will end up in having a conjugated hyperbilirubinemia. The patient's bilirubin will be conjugated, but it's not going outside, so it's conjugated hyperbilirubinemia. Okay, for post-exposure prophylaxis. Rohit, if you have gotten exposed to your any of the HIV patient, and if you're talking about your case or any of your friends' case, I would say the best person to comment on this is you and the doctor whom you see, they are seeing you, right? Okay, if it's for a patient, see, if it's for a patient, it's based on what is the type of exposure. There are lots of things, right? So it'll differ a lot, but generally, most of the early test, the good test can pick them up very, very early, but at least give it a month or a two in order to do it because the antigen, antibody, everything is based on how the body responds. Month or two, observe. After that, do a test. The accuracy will definitely be much better. Okay, 10 days is very short. Still, I can go for a viral RNA, but still, month or two will have a much of a more confident thing. Fine. Okay, perfect. No need. This is for an need target. This is for MBBS students. So let's see you after some time. Okay, that's about jaundice. Now let's go to alcoholic liver disease. Alcoholic liver disease will PEP must have been a month older, right? They can go ahead with Rohit for sure. Okay, still not to panic. PEP if implemented properly will have a very good success rate. Don't worry about it. Yeah. Okay. So spectrum of an alcoholic liver disease. So first, alcoholic liver disease, you'll have a history. So like a long answer, I want you to write the data given. So the most probable diagnosis is alcoholic liver disease, right? So alcoholic liver disease has a spectrum. You must have seen this image in Robbins and most of the textbooks. It's a normal liver, exposure of alcohol. It will result in fatty liver. Okay, no issues need. Exposure of alcohol can result in your alcoholic steatohepatitis. It's inflammation as well as the fatty liver. Okay, then it both of them might progress to an cirrhosis. Cirrhosis is the only one which is reversible or irreversible. It's irreversible, right? This can come back. This can come back if the person is stopping the alcohol, if there's an abstinence, right? Both fatty liver can come back to a normal liver. Steatohepatitis can also come back to a normal liver, but this is undoubtedly an irreversible stage. You cannot do anything. It will progress to a complete liver failure, and the worst case scenario can become a hepatocellular carcinoma. This is spectrum of an alcoholic liver disease, fine. So risk factors, though we know the primary thing is alcohol, but still not everyone drinks will have an alcoholic liver disease. So there are multiple ifs and buts for us with respect to an alcoholic liver disease. One of the important risk factors, gender. Females are more prone, multiple reasons. One of them is the gut flora. Gut flora kind of pushes more of alcohol inside, more of pro-inflammatory cytokines. Females are definitely more prone to alcoholic liver disease for the same amount of alcohol, right? Next is polymorphisms in the enzyme. If the metabolizing enzyme is abnormal, obviously if it's more active, definitely the amount of metabolism will be more, amount of NADP, NADPH produced will be more, free radicals produced will be more, obviously you'll end up in having more damage, right? Then is coexisting liver conditions. An alcoholic liver disease plus any other hepatitis. Patients already having an hepatitis. Alcoholic liver disease who is having an hemochromatose, right? Everything, fine. Great, Deepak. Very thank you for being here, and hopefully your second year is going good. Fine. Okay, that also will obviously will increase the damage to the liver. Any coexisting liver conditions can definitely increase the liver damage. That's also a risk factor. Last but not least, and the most important thing is the quantity of it, right? So quantity actually depends on what liquor you're consuming. There are many ifs and buts here also. But if a person takes daily 80 grams of alcohol, it's not the ml, it's gram, right? It's gram is equal to the weight and the liquid ratio will be there. 80 grams of alcohol daily consumed will definitely increase the risk of hepatic injury. And obviously it should be there for months and years. It should be daily intake continuously for months and years. It will definitely increase the risk of hepatic injury. If the person is going to end up in a very severe fulminant damage or cirrhosis, so it should have a daily consumption of 160 grams of alcohol. Again, it's weight, not the ml. It will definitely result in a severe hepatic damage or even can result in a cirrhosis. Again, like I said, it's based on the quality, everything, right? If it's not a well-formed alcohol, they will say outside it is 5%. But you know our country, right? They will reduce the quantity of alcohol. Here is the only place where adulteration is good. When you reduce, obviously it's going to save the patient, right? So these are something about risk factors. Here, with respect to alcoholic liver disease, I want you to write pathogenesis differently for different stage. For fatty liver differently, for your steatohepatitis differently, and for your cirrhosis differently. Or you can combine everything and say fatty liver, steatohepatitis, cirrhosis combinedly also, right? But I would say that if I have different pathogenesis, it makes much more sense because different damage will cause different outcome, right? The most important pathogenesis of fatty liver, especially in alcoholic, is the metabolism of alcohol. So once you metabolize alcohol, so alcohol gets metabolized from alcohol with the help of an alcohol dehydrogenase. It becomes aldehyde, acetaldehyde to be specific. Then it becomes your acid, right? Then have an aldehyde dehydrogenase, ALDH for aldehyde dehydrogenase, which gets metabolized. It's a dehydrogenase. When any time a dehydrogenase works, what will be the conversion? What will happen to NADP, NADPH? NAD will be converted to NADH. Any dehydrogenase works, I'll have NAD getting converted to NADH or NADP getting converted to NADPH. That's how alcohol also, aldehyde also works, right? Which produces acetic acid finally, if you want to complete it. So whenever there's a metabolism of alcohol, by default, there's going to be excess amount of NADH. This excess amount of NADH will definitely alter the metabolism of fat in the liver because it will increase the metabolism of production of free fatty acid, production of triglycerides. Everything will be altered because there are more NADH. The fatty acid oxidation cycle requires NADH, right? So this alteration in NADH will alter the fat metabolism. If you're very confident about biochemistry, write what exactly it will alter. Or if you're like me, not very confident in biochemistry, say it alters the fat metabolism, resulting in deposition of triglycerides. Deposits excess triglycerides in hepatocytes. Okay, that's what will be the primary pathogens of fatty liver in alcohol. In addition to this, the patient will consume lots of food along with alcohol. That also will increase the fatty acid, and you're going to have deposition of fat triglycerides in hepatocytes. It's triglyceride deposition, not a fatty acid deposition. Gross, you know that. It'll be an enlarged liver, and the most important thing is it'll be yellowish in color. That's a finding, and it'll be greasy in texture. A greasy enlarged liver, obviously that's nothing much to write in case of fatty liver. You must have seen your specimens for fatty liver as well, right? So we know the gross, the microscopy, right? Microscopy, what is the color of fat? No one will ever forget that, right? Fat by default is going to be clear, right? So what is difference here is microscopically there are two types of fatty liver for me: macrovesicular steatosis and microvesicular steatosis. In alcohol, both of them will be seen. Initially it will be microvesicular, later on automatically it becomes macrovesicular, right? So initially I'll have microvesicular steatosis. It will be found initially, and initially it will be found in zone 3, which is centrilobular zone. And how you find microvesicular steatosis? Tiny fat vacuoles in the cytoplasm. If you want, draw diagrams which will not displace the nucleus. Macrovesicular steatosis, here the entire fat globule will push the nucleus to periphery. When the fat globule pushes nucleus to periphery, that's macrovesicular. That's a classical finding in microscopy as well, and it will be seen a little bit in later stage. Both macro and micro is also obviously reversible. Yes, you can write it, Rishikesh. Petechiae infection suggesting, developer king, I would say that if it's a petechiae and just petechiae infection, I would first think of an ITP. Was there any other finding? Please give me a complete answer. I'll give it, because just petechiae infection, no lymphadenopathy or no leukocytosis or no blast, I will not think of an ALL. It could be a dengue fever. Following that, ATP, right? Possible. Fine. Yes. See here, like I said, you can draw a diagram. Lion, I think the diagram will help us to sort out easily. Fine. So if you draw hepatocytes, again divide two things. Hepatocytes will be round to polygonal. Draw them round to polygonal in shape. If you want, completely shade them pink in color. That's how the normal thing will be. Okay. Then have a nucleus in the center. If the nucleus is in the center, then it's microvesicular steatosis, because it's not separating, pushing the nucleus completely away. And draw tiny vacuoles here, right? That's microvesicular. Fine. If it's a macrovesicular steatosis, I'll have the entire thing. The nucleus will be in the periphery. It will be pushed to the periphery, and the entire hepatocyte is filled with a huge vacuole. If it's entirely filled with a huge vacuole, we call it macrovesicular. That's the difference between micro and macrovesicular steatosis. If you want, you can write it as well. But in alcohol, by default, you'll have both micro and macro. Initial stages, no one is going to ever notice there's a liver damage. It'll be both micro and macrovesicular steatosis, fine. I would still think of an just petechiae and a past infection in the recent past. An acute ITP will be my first diagnosis. One infection and one petechiae, I won't think of a ALL. Fine, developer king. Okay, that's with respect to your fatty liver, right? Then you'll have the second stage of alcoholic steatohepatitis, right? Steatohepatitis has a different pathogenesis. In addition to the fat deposition also will trigger that. In addition to that, there are two things. Once there's going to be excess fat deposition, excess triglycerides, this will trigger excess production of reactive oxygen species, because by default, triglycerides of fat is an inflammatory tissue. It will definitely increase the pro-inflammatory cytokines. More pro-inflammatory cytokines will be there, and when there's more pro-inflammatory cytokines, obviously you will have more amount of reactive oxygen species, which will cause damage. That's first. Second, the aldehyde which has been produced. Aldehyde per se is a toxin. Aldehyde is the one which destroys your liver, destroys your heart, destroys almost everything. If you remember methanol and formaldehyde, which can also cause blindness. Aldehyde is a toxin, right? This can directly cause hepatocellular damage. Okay, can directly cause hepatocellular damage. So these are the two primary insults by which a steatohepatitis results in, right? One is aldehyde related, one is your fat related pro-inflammatory cytokines, right? So what happens is when both of them are going to get damaged, one, I'll have both inflammation. Second, the damage per se will also result in your one classical structure called as an Mallory-Hyalin, or if you don't want Mallory, you can just call it Mallory-Hyalin or a Mallory-Deng bodies. Fine. Okay, because the damage is going to change the architecture of the entire hepatocyte. Fine. Okay. So in microscopy of steatohepatitis, fine. Steatohepatitis is not just hepatitis. So first, fatty change will still be seen. Fatty change always will be there in background, be it just a fatty liver or a steatohepatitis. Fine. Perfect. Any damage to the liver, the first change, what we read in the first chapter 1 year back, is swelling. Here also I'll have the same swelling. Mallory-Hyalin and Mallory-Denk is same, Samantha. Okay. So you'll have swelling. Instead of swelling, we use the term ballooning of hepatocytes. By default, it'll have balloon. It'll become bigger, which is nothing but a slight damage to the hepatocytes. The water entering inside, the cell is becoming bigger. That's all, right? Third, and one of the important findings is neutrophils accumulation, right? neutrophil satellitism. So in few places surrounding the hepatocytes, you'll have lots and lots of neutrophils. This is a very important finding which differentiates alcohol from non-alcoholic fatty liver disease. Neutrophilic satellitism is an important finding. If you want, remember, because we do have inflammation, we need some inflammatory cells for evidence for that, right? The last but not least is a very non-specific finding, right? In the first word itself is non-specific. Mallory-Hyland or a Mallory-Denk bodies. Denk is a person who said that it's not just some random hyaline, right? It's a destroyed ubiquitinized cytokeratin, right? So Mallory-Denk bodies, it's nothing but an accumulation of your damaged proteins or damaged cytoskeletal proteins, damaged cytokeratin 8 or 18, right? Which gets accumulated, so it has a very different appearance, right? If you want, draw a representative diagram here. So Mallory-Denk bodies, the first thing is the architecture of the cell will not be exactly round or polygonal. It will differ. Nucleus will still be there. It's a destroyed protein, right? Destroyed protein will be darker or lighter. Again, going back to our first classes, it will be darker, right? So you'll have completely dark accumulation of protein here. Just scribble something dark, that's more than enough, right? It's actually a thick, ropey accumulation of a pink material. It was pink in color. Mallory didn't know what it was, so he named Mallory-Hyland. Denk came and said that it's not some random pink color, it's cytokeratin damage, so we call them Mallory-Denk bodies, right? So this thick, ropey accumulation inside the cell is your Mallory-Denk or a Mallory-Hyland body, right? It's a very non-specific finding. I'm sure you know by this time you will be seeing lots and lots of liver damage, not only in case of alcohol, right? That's one. Next, we'll go to alcoholic cirrhosis. This also is reversible. Good evening, Rajshri. Fine. So alcoholic cirrhosis, it's fibrosis, right? So to call it fibrosis, I need to have your transforming growth factor beta. Without TGF beta or cytokines which produce fibrosis, you cannot have fibrosis. One of the important thing in alcoholic fibrosis is alcohol per se, the pathogenesis can directly activate a cell or stimulate a cell in the liver. Can anyone tell the name of the cell? This cell also stores vitamin A. That's a clue. We have a cell called as stellate cell, thick rope-like, ropey. Okay, it activates stellate cell. So stellate cell, once it's activated, normally it stores vitamin A. That's a normal function. Once it's getting activated, they transfer them into a myofibroblast, or they kind of have the healing quality, right? It transfers them into a myofibroblast-like structure, like a metaplasia. So once it becomes a myofibroblast-like metaplasia, it automatically is going to produce increased TGF beta. If there's TGF beta, by default it will produce collagen, and whenever there's collagen, there'll be fibrosis. It's undoubtedly a collagen fibrosis. It's a healing, that's all. So instead of saying this macrophage became activated macrophage, here stellate cell is going to drive everything, which is going to produce the healing, right? Gross liver will be shrunken. The most important thing, liver will be nodular, and the nodules will be uniform. Nodules mean it could also be cancer. Cancer nodule is also nodular, right? But here's a uniform nodules throughout the surface of the liver. I cannot have one lobe of the liver alone cirrhosed. It's a complete process involving entire liver, right? So if it's wanted in microscopy, the first, again, starting point, where it will start? We did the same thing in case of an fatty liver also, right? Which zone will it start? Zone 1, zone 2, zone 3. It'll always start in the zone 3, right? Damage always starts in zone 3. Initially, the damage will be pericellular damage, right? It'll be a pericellular damage. We call it a chicken wire fibrosis. That's how the initial fibrosis starts. It starts in zone 3. Initial damage will be pericellular fibrosis. Around every cell, I'll have fibrosis. We call it pericellular fibrosis, or it's called as chicken wire fibrosis. Just surrounding every hepatocyte, I'll have it. Later on, obviously, it'll end up in having full-blown regenerative nodules. You'll have regenerative nodules. That's what the definition of cirrhosis is, right? So it's a nodule. How do we classify cirrhosis? Zone 3 is, I'm not sure how to call it an outermost or innermost. Close to the central vein, we call it zone 3, Rishikesh, fine. Close to the portal triad, we call it zone 1. There are vascular zones. Portal triad will have your portal vein and hepatic artery. So the one which is very close is zone 1. Farther away is zone 3. Fine. Okay. So regenerative nodule, we divide them into micronodular cirrhosis and macronodular cirrhosis. Less than 3 millimeter is micronodular, more than 3 millimeter is macronodular. Okay. By default, alcohol will be a combination of both micro and macronodular. Initially will be micro, later on becomes macro. We call alcoholic cirrhosis Lane-Axe cirrhosis. The person who discovered it, we call them a Lane-Axe cirrhosis. By default, cirrhosis is irreversible, right? We have not discussed anything about the clinical manifestations yet. Without that itself, you can easily write for 2-3 pages. Obviously, it's cirrhosis. You must have seen case of cirrhosis in your medicine ward. You can write starting from your hair loss, fetal hepaticus, your spider nevi, gynecomastia, lots of things. Ascites, pot belly, all the portal hypertension problems, right? Your variceal bleeding, can have hemorrhoids. You know many things about cirrhosis than me. Fit in accordingly. In liver failure, when there's cirrhosis, I can write all this. If it's not liver failure, alcoholic hepatitis might have a little bit of inflammation induced pain in the right hypochondrium. Fatty liver is asymptomatic. You guys can have fatty liver, I can have fatty liver, right? It's how it is. Fatty liver. Fatty liver will not be symptomatic. Rest will have its own symptom based on the stage of the disease, fine? That's about your alcoholic cirrhosis, fine? So again, if you want to draw a diagram, you can draw a diagram for cirrhosis. Put a nodule. See, what is required is a representative nodule. It's cirrhosis, right? It's fibrosis, collagen fibrosis. So what stain can be used? Wherever possible, with minimal effort, explain to the examiner, you know what is pathology mean, right? So use Mason's trichrome stain. So write them. Why to do H&E? When I can imply in the same time to an examiner, see, I know a little bit more. A Mason's trichrome stain is useful to identify fibrosis. In Mason's trichrome stain, obviously the liver will be pink in color. Put around, shade it pink in color, tell it's liver regenerating nodule. What will be the color of fibrosis in Mason's trichrome? You know the answer, right? It's blue in color. Blue color, fibrosis. Blue color, fibrosis. It easily explains to you that you know about Mason's trichrome and it's a very easy representative diagram. That's all, right? If you want, you can write collagen fibrosis, because fibrosis will be blue in color, and your pink color regenerative nodules. Fine. Let it be neat and legible. No one expects an beautiful cells to be seen in a diagram, right? That's not required. Just a representative diagram of what you are trying to convey. That's more than enough, right? It's an attempt which matters. I'm not here judging for your artistical beauty. We are judging for your way to become a good doctor. For that, most of the doctors who don't have a very good artistic sense. Fine. Okay. That's about the second question, right? Let's go to the third one, portal hypertension. Okay. Before I have not defined portal hypertension when we took a normal class. By this time, I'm sure you know a little bit about medicine. You must have encountered portal hypertension. So I'm introducing a definition of portal hypertension, right? Good evening, Banana Shake. Portal hypertension is an increased pressure within portal venous system. The way it is said is, it's actually based on the pressure gradient. It's not just the pressure. The difference between the portal veins and the hepatic veins, if the gradient is more than 6 millimeter or more, I call it portal hypertension. Is the difference, right? Or some books say that more than 8 millimeter per mercury or more than 10 millimeter mercury of portal pressure alone is also told as portal hypertension. But this is the right definition. The pressure gradient of 6 millimeter of mercury or more between the portal and hepatic veins or portal vein and the inferior vena cava, the gradient is called as portal hypertension, right? How do you differentiate portal hypertension? What are the types of portal hypertension? We have three major things. Prehepatic, same like your jaundice, right? So we have prehepatic, hepatic, and post-hepatic cause. Ultimately, someone should increase the pressure. Hepatic cause is the easiest one. Cirrhosis of any cause. Any cause of cirrhosis, not letting the portal vein push the blood inside normally will cause portal hypertension. A massive fatty change. A very big fatty change, again, not letting the blood flow properly can have. Any infiltrative malignancy, primary or metastatic, amyloid. See, all this, what they do is, all of them is going to reduce the blood flow into the liver because they by default are causing some hindrance. So in order to maintain the flow, the portal pressure increases. To maintain the blood flow, obviously there's an increase in the portal pressure, the portal veins pressure. Okay. It's simple. Resistance is there, so I'm going to increase the pressure. Same like total peripheral resistance causing a systemic hypertension. This causes portal hypertension, right? Prehepatic, I can have a thrombosis or a blood clot in portal vein. We know lots and lots of conditions of blood clot. We must have read in hemodynamics chapter like a factor V laden mutation or drugs causing it or inactivity, DVT, embolism, anything thrombus in the portal vein can cause it, or it could be a vascular anomaly. Okay, so here if you want to remember this in detail or just write structural anomaly, right? See, let's say I'm having a normal portal vein like this. Fine. Sometimes, let's say some of times the portal vein can ramify like this. When it ramifies, what happens is it becomes shrunken, it becomes smaller. That's what they're mentioning that prehepatically, if there's lots of ramification in the portal vein, it can reduce the caliber. Once it reduces the caliber, automatically pressure will increase. Your Bernoulli's theorem in your physics, the same concept. So if you want, just remember this or don't forget this. Obstruct, thrombus or a clot obstructing portal vein, prehepatic causes. Posthepatic, we know anything which caused your chronic venous condition, something like that, a right-sided cardiac failure, constrictive pericarditis, or a hepatic vein thrombosis, right? It could be an hepatic vein thrombosis. We can call it an Budd-Chiari syndrome. Okay, so Budd-Chiari syndrome also will result in portal hypertension. Fatty liver, as such, is if it's not progressing, it's not a problem, Samantha. Here, when it's so huge and obstructing the vein flow, it can result in a portal hypertension. Again, not a common cause. Cirrhosis by default is cirrhosis of any cause. This accounts to close to 85 to 90% of portal hypertension. It's cirrhosis and portal hypertension, that's all. Rest everything is follows to fill the pages. Rest or everything together costs 10% of portal hypertension, 90% is due to cirrhosis only. Fine. Okay, perfect. So now, what are the outcomes of portal hypertension? Like I said, cirrhosis and portal hypertension are dealt always together. So instead of writing outcome of portal hypertension, we can use the term cirrhosis and portal hypertension, which means all these four findings we can write in cirrhosis also. Ascites, portosystemic shunts or your varices, we have your hepatic encephalopathy and congestive splenomegaly. These are the four major outcomes of cirrhosis as well as cirrhosis and portal hypertension. Fine. Okay. Ascites. What do you mean by ascites? Just few words. Ascites is nothing but excess fluid in your peritoneal cavity. Right? It's excess fluid in the peritoneal cavity is termed as ascites. This fluid is an exudative fluid or transudative fluid. Since already we know about ascites in detail, we know about exudate, transudative also. Is an exudative fluid or transudative fluid? It's an transudative fluid, right? It's not an exudate. Exudate is due to inflammation related. This is not an inflammation related. This is a pressure alteration, right? Perfect. It's a transudative fluid, right? So here it's a transudate fluid. It's not an exudate. And here the primary reason for ascites is reduced albumin, which obviously reduces the oncotic pressure. That's one. This reduced albumin is due to your reduction in your liver's production of albumin because it's cirrhosis and portal hypertension always, right? High pressure, fine. And also increased portal venous pressure that also can push. See, there are two things. One is reduced oncotic pressure, increased hydrostatic pressure. Both of them will push the fluid outside. It's an outward force, right? Both of them will increase the outward force. So automatically fluid accumulates and it results in ascites. The primary reason is albumin related and increased portal venous pressure can also contribute. Hello Pratik. Okay, that's one. Then portosystemic shunts, right? So portosystemic shunts are nothing but because of the increased pressure, there are places where the portal venous system and the systemic things will connect. Those places will have dilatation, right? So you know many portosystemic shunts than me. Any classical places where you can see portosystemic shunts? Any classical place of portosystemic shunts? One is esophageal varices, right? Esophagus is one, the lower end of esophagus, variceal bleeding, that's by default a very classical phase, right? Hemorrhoids, it's also a classical place where you have portosystemic shunts. Someone yesterday said, I think Samantha said about caput medusae. Caput medusae is a classical place of portosystemic shunts. Bad area of liver, retroperitoneum, though we cannot see them. These are also areas of portosystemic stents. Okay, all these are areas of portosystemic stents where you can see them, right? It's a complication of portal hypertension because of the increased portosystemic pressure. What happens is there's a reversal of flow from the portal to the systemic circulation, which results in dilatation of the collaterals. That's the reason you're going to have all this enlarged variceal bleeding in multiple places, right? Perfect, right? Rectum, or I'm writing hemorrhoids, you can write whatever it is, anywhere. Salman, it's primarily for a prof. I'm aligning it to how to write an exam paper. Same concept comes in NEET PG also, but I say it's primarily oriented to prof. Fine. Okay. Next is hepatic encephalopathy and congestive splenomegaly. Fine. Hepatic encephalopathy, because there's a you have you seen case of hepatic encephalopathy in your colleges? Anytime? Hepatic encephalopathy? If you've seen hepatic encephalopathy, I think you can definitely write a little bit about them. So there'll be an alteration in the behavior. The patient might have stuporous coma. It can progress over days or weeks, and a classical sign cause an astraxis, right? So it'll be an altered sensorium. That will be the clinical finding. How they'll present with could be coma, just or an just disorientation, right? And astraxis. Astraxis or your flapping tremor. There's a classical sign which can be elicited in case of a hepatic encephalopathy. So why do we have hepatic encephalopathy? Because of accumulation of lots and lots of ammonia, right? So the ammonia, normally ammonia is transported to the portal vein, from the portal vein to the liver, and it's metabolized. In case of an extremely severe liver disease where it's not liver is not able to take care, or a very severe portal hypertension, it's not reaching the liver adequately, ammonia diffuses and causes CNS toxicity, right? So here, because of excess ammonia in the blood, the reason for excess ammonia is liver not able to metabolize. That's one. Second thing is excess portal pressure results in less delivery of the ammonia into the liver. Both of them can be the reason, but primarily liver failure, because I said portal hypertension 90% of them are due to liver failure. That's all, right? Ask here. Okay, excess ammonia, which is going to cause CNS toxicity. That's the reason for your portal hepatic encephalopathy, right? Fetal hepatic is also similar way. When the ammonia breath can come, it has a very bad order called fetal hepatic, is fine. Last but not least, congestive splenomegaly. Since the portal pressure is more, the splenic vein which joins the portal vein will not be able to drain properly, right? This is due to reduced drainage of the from splenic vein. Because of the increased pressure, the congestion happens in the spleen, right? So this results in increased back pressure in the splenic vein. When there's an increased back pressure, similar to your congestive chronic venous congestion of liver, this is going to result in a congestive spleen. Okay, so congestive spleen will have an physically on examination, you'll have an enlarged spleen. Cut surface, it might be a little bit more red and boggy, right? And microscopically, you'll have one classical appearance. This people love. I don't know why. What's a structure there? We call it gamma antibodies, right? A classical finding cause in hemocytotic bodies or gamma antibodies. Okay, gamma antibodies are microscopic finding which you can see in case of a congestive splenomegaly. Fine. Salman, you can ask me here if it's during a class or I am available on Instagram mostly. You can ping me on Insta, or we do come live very frequently. Ask live doubts. Okay, so these are the main four output of portal hypertension. The same four output you can write it for your cirrhosis also. In addition to multiple findings you must have seen in cirrhosis, you can add this to your classical cirrhosis as well as portal hypertension. Fine. Okay, gamma antibody is nothing but an there will be, if there's congestion, there will be hemorrhage. When there's hemorrhage, the RBCs will die. You will have hemocytin and calcium. So gamma antibodies is nothing but microscopic structure where you have deposits of iron and calcium in the congested spleen. That's what is called as gamma antibodies. Fine. Fetal hepaticus is nothing but this breath goes outside, the ammonia is not being metabolized, it can go into the brain, it can come outside. That's fetal hepaticus. That's a very bad order which comes in patients with cirrhosis of liver and portal hypertension. It's okay, Brisha. Okay, that's all for today. Tonight again at 7:30 p.m. we'll be having RBC disorders. I'll send the PDF in some time. I've made it. I just have to send it to you guys. RBC disorders, everything is important in RBC disorders. Don't skip, fine. We'll just have a very quick template, 2 pages for every disease. We can revise RBC disorder in no time. Okay, let's see. Hopefully, we'll be able to complete RBC disorders by evening, fine. Flapping tremor is a classical clinical examination finding. I think Samantha, when you go to your medicine posting, you will see them, fine. Today evening, yes, Rishikesh. Same YouTube channel. Come back by today evening. We'll take a quick discussion on RBC disorders. Manya will come. We'll discuss that during WBCs. I'll definitely take about what to write for leukemias, lymphomas, everything. We'll discuss them when we come to WBCs. Does everyone have 7 and 12 mark questions? Is that so? Short answer, long answer, right, Rishikesh? For every short answer, use this template. Long answer, write why, what is the why you are coming to a diagnosis. We have discussed few long answer formats previously. Have a look at them and then write whatever they are asking for. They'll ask like talk about the pathogenesis, talk about the microscopy, 2 marks, 3 marks, right? Like that you can write easily, fine. Okay. NMC screwed our entire life, right? So there is a person who for them is 5, 10, and 20 marks. Some of them is 7 and 12 marks. Okay, it's ultimately 8 and 5 marks. Okay, it's ultimately a long answer and a short answer, right? For short answer, use these templates. For any short answer, use this template. If it's a neoplastic or non-neoplastic. It's a long answer. The first thing is, why did we come to a diagnosis? Arrive to a diagnosis. Then long answer, they will give you subheadings. Talk about the pathogenesis, 2 marks. Talk about the clinical symptom, 2 marks. Investigation, 2 marks. Write that, fine. For every short answer, have all this, be it a 5 mark or a 8 mark or a 3 mark or whatever it is. Have this thing for a 5 mark. Then for a long answer, the template will be already provided in your college, fine. Okay. Thank you guys. See you back by 7:30 tonight. Bye-bye.